Hello, everyone. Hope you're having a good week so far. I just wanted to go over our topics from last week. I don't have any quiz questions to go over because everyone got 100 on the quiz. So, yay! That's what this little gold star is for. So, I have no quiz questions to go over, but I did want to go over some of the topic areas, just briefly, the discussion. Um, some of the info from the discussion, mainly the first discussion topic. I'll touch on the second one too. That was kind of more um, opinion based, but the first one I just want to touch on. So in our discussion, we had suppose a for-profit hospital is adopting a rule of profit maximizing, not-for-profit, um, using the Newhouse model, which hospital is likely to be more efficient, etc. So I had put up a post in the discussion board, but I'll just talk a little bit about it. So in in a not-for-profit hospital, keep in mind a not-for-profit hospital, and you know these are likely things you already know, but a not-for-profit hospital is not necessarily not trying to make a profit. They are trying to make a profit. And the reason they want to make a profit is so that they can continue their mission. And I had posted this, but um, I worked my first job in the hospital. I worked at Our Lady of Lourdes Memorial Hospital here in Binghamton, New York, and they're Catholic, faith-based hospital, Catholic hospital, not for profit. Actually, all hospitals in New York State are not for profit by law, and so it was. I had the opportunity. I worked in finance. I had the opportunity to work for a CFO. Really good guy, taught me a lot, and he. One of his favorite sayings is "No margin, no mission," and that's not, it wasn't something he made up. It's very common in the healthcare world, but he would say that all the time. And what that really means is, if you don't have a margin, meaning that you're not working in the black, you're not making money, you don't have, you can't do mission-based activities, so you can't go out and help those that are less fortunate. You can't get out, and we had a big RV. It was referred to as the mammogram van, but it was a huge RV that had mammography equipment in it, and they would go out and do mammograms throughout the community. They weren't necessarily free. They were free if you qualified financially, but they would go out to places like senior centers, different community events, etc. Do mammography for free if you qualified, or low cost. They did sliding scale, or you could use your insurance as well because it was obviously part of our organization. We had a dental van, same thing. It was a big RV that would go to schools and treat kids that had no dental insurance, which um, a lot of people don't have dental insurance, and even if they do, a lot of them don't have dental insurance that provides very much coverage. So they would go out and do dental care, preventative care for kids in schools. That was a mission-based activity. Um, they had just a multitude of different mission-based activities. We had a clinic that provided. It was like a pregnancy type clinic. It provided prenatal care and care for patients throughout their pregnancy for moms that couldn't get care elsewhere. So things like that were really important to the mission of our organization. But if we didn't make money, they would go away. So no margin, no mission. We were there to make money. So what would we want to do? Would want to be as efficient as possible in our practices to make sure that we were able to make money, and therefore be able to support those mission-based activities, having great charity care programs for those that came to us that were in need, etc. So that was the not-for-profit. That's the kind of the Newhouse model. Utility reigns in the Newhouse model. In a for-profit hospital model, they're looking to maximize profit. It doesn't mean that they don't want to be efficient, but oftentimes in a for-profit hospital setting, um, quality tends to trump efficiency. So in a for-profit hospital, they may be charging more, and therefore and this is where, interestingly enough, some some of what you heard in the video that wouldn't stop playing or always started playing. They talked a little bit about that in there. Patients that would say pay more to go to the university hospital and have an MRI rather than have one at the community hospital when they're both running the same magnet, same brand, same everything magnet. They're going to get the same result generally. I disagree with that a little bit. You can get a slightly different result depending on who's reading it. And you may have a more skilled radiologist at the other, the university hospital than you would have at the community hospital. But the magnet itself is exactly the same. So you are going to get the same result likely from both facilities, but that university hospital may charge more. And if you have a percentage-based copay, which a lot of us do now, you're going to end up paying more in the long run. And so it's definitely a situation where that for-profit hospital is not necessarily being efficient, and the notion that they're perhaps charging more may even give the illusion that they are higher quality, because a lot of times quality equals price equals quality in healthcare, but that is somewhat of an illusion, and that's where those folks in our second discussion we're really talking about disruption and how can we disrupt this disruptive leadership. Although some of us think of disruption as a negative term, disruptive leadership in healthcare is really where we need to go to try and disrupt some of this thinking that it doesn't need to be more expensive to be better. It just needs to be better to be better. It needs to be a higher quality. But to stick with question one for a minute. So the for-profit hospitals they still work toward efficiency, but they are likely less efficient than the not-for-profit hospital, who is really working to remain efficient in order to maintain their mission. The second question, the medical arms race. So when you think about the medical arms race, it's really, and I talked about this in the discussion board as well, but it was really in talking about how I just want to bring up this thing I had typed out because I don't really want to just keep restating over and over what I've said, but it's how all of these facilities were really arming up against each other to be the one to provide that product. So the hospital in the Pittsburgh area is a perfect example of the medical arms race, because each facility, and I'm seeing it here. Markham made a great a great analogy, keeping up with the Joneses, where every facility was kind of arming up to one another to make sure that every facility could provide the same resources, so that Susie usually gets her stuff done at Hospital X, but Hospital X didn't have the appropriate MRI, so she might go to Hospital Y to get that MRI. Now likely she's going to come back to Hospital X because that's where she always comes, but there was a fear that, if she sets foot in Hospital Y, she might like it better there, so we better get an MRI as well, even though there's one a mile up the street. So why would they need to do that? And they really all, everyone was arming up against each other to make sure nobody lost business. And it's created, in some cases, a great access for patients. So there is some positive, but it's created such, overkill. So much wasted money for anybody except the device salespeople, I guess, or the equipment salespeople. There's so much stuff in the in these areas that is unneeded, and honestly used not as often as it should be. And even with physician practices, they're being bought up in chunks. So and then if they're not used by that organization, they divest themselves of them. They'll move physicians about through other parts of their organization and close down a clinic. So then it'll leave parts of communities that no longer have access to physicians that used to be there, perhaps as a private physician practice. They got bought up by a larger organization, and then the organization saw they weren't making money there, so they divest that clinic and spread those physicians throughout the organization. So it's really not helped communities as much as it's helped them, if that makes sense. It's been less, there's more con than pro to the arms race overall. But that is where um, it gets um, it gets to the point where you need to be disruptive, and that's where the folks in that video have talked about disruption. Um, sharing resources amongst hospitals. Um, coming up with thinking outside of the box, coming up with ways to work with one another instead of against one another. Unfortunately, in the Pittsburgh area, that is not really what happens a lot of the time because of the massive competition between the two big entities. But hopefully across the country, there is more of that going on, and hopefully eventually everyone will make friends again in the Pittsburgh area because there's such a need for that, honestly. But so that's really all I have. It was just that first one I really wanted to share some info on. But if you have any questions, this coming week we are doing, week 5 is talking a bit about a few different things, quality of care, things like defensive medicine, talking a little bit about medical malpractice as well with regard to quality of care. But then the workforce, nurses and whatnot in the workforce, and then some about pharmaceuticals. So there's a lot in the class this week. I know that's a lot of reading, the 3 chapters, but feel free to rely on your slides as well. That's where the slides are in there now. And if you have questions on any of the content, I know the economics content is heavy. Please ask. That's what I'm here for. I'm happy to put up some lectures if you want some. But lectures on economics are not any less heavy than readings on economics. But if I can help to try and dissect any one of the principles or any multiples of the principles, I'm happy to do that if you think that'll be helpful. But otherwise, I will look forward to seeing everyone in the discussion boards this week. Okay, thanks so much.